thank you very much. It's again great honor to be with you, and I'm a friend of Dr. Şahin, and my wife is also coming from Turkey, so there is no issues, and we are all friends. I try to bring some of advantages of endoscopic approach, and actually it is nothing new. 2001 already Michael Mag introduced a paper about minimal invasive and robotic surgery, and at that time we didn't read it, or we had enough to do, and we forgot to take these also in our advantages. So now we have 2024 talking about the advantages and disadvantages of endoscopic surgery. I think endoscopic valve surgery is a high-end and latest level of minimal invasive surgery. You see everything on your operating table. You have a direct vision of the situs. You have a very good visualization of all your anatomic structures. You do the surgery on the patient. You're not away from the patient on the console, and this is a very focused and dedicated team approach. You have a wide accessibility to all the valve structures. You can see everything. You can work on all of your valves without any restrictions, and not only for simple pathologies, and now we are moving to more and more complex procedures, doing root surgery, doing complex redos of aortic mitral valve and aorta. So it is challenging, but it is feasible. The goals are very well known, less operative trauma. You have heard about Dr. Şahin. Also, all of these advantages you get also through endoscopic approach, but I think from our view, you have less operative time. It is very good to reproduce, and you have shorter time of surgery. You see two different sites of operations. On the left side, you see endoscopic aortic valve replacement. Very simple. It is no rib retractor. You have a 3D scope. You have a chit-put clamp, and this is the LV vent you can see, and you can do with this work port everything through the mini thoracotomy, 4 centimeters incision. And on the right side, you see a robotic aortic valve replacement. I try to count the incisions which patient have get for this operation. You have 4 arms. The camera is going through the work incision, and it is very crowded, and actually for the first view it is very complicated. So I think the setup is very simple for endoscopic approach, and all the other advantages like lower cost, simple setup, reduced operative time, and lower maintenance and wider availability I'm going to show in the next slides. So in our experience, you can do actually through a right anterior mini thoracotomy, mitral tricuspid valve, ASDs, multi-valve surgeries, and also very complex cases of aortic root, ascending aorta, HOCM, and aortic valve, and also in very rare pathological cases like situs inversus, pulmonary valve replacement, mid-cap and multi-valve vessels, mid-cap vessels through left mini thoracotomy. But not every robot can do every procedure. You have a wide or rare availability of the robotic approach. So I've tried to find the availability in the literature, and it is very, very useful and common, as Dr. Şahin said, for mitral valve, and it has a huge, long-standing experience. But for the others, I couldn't find any reproducible papers for doing surgery through the robot. So this is the endoscopic marking if you go for a double valve replacement through a mini thoracotomy, and this is the marking for a robotic surgery. How you try to find the incision sites for your trocars, and then it is, as Dr. Şahin said, probably more complicated and complex to reproduce. And again, if you have your endoscope, this is on the left side your total endoscopic approach. You see the percutaneous cannulation in the groin vessels. You see the mini-tracheotomy for double valve replacement. And on the right side, you see the aortic valve replacement with setup in a high volume center. So it is very, very complex. And this is the robotic room, as you can see. Please don't look at the shoes. This is the surgeon on console. These are the team trying to do the surgery. So there are two different surgeons doing the same procedure. And the only one who is looking at the clock is this lady, and it is 12:30. So it means it takes long for these cases doing the procedures, and you can see all the instruments which you need for a robotic assisted surgery with all these points which may be a little bit complex to do the operation. And this is the setup of a total endoscopic. So we have some instruments, long-shafted instruments. We have 3 monitors, one 2D for the scrub nurse, 3D for the assistant, and the surgeon is looking on the other monitor with 3D 4K visualization. So I tried to find how is the reimbursement and how is the financial aspect of the robotic versus endoscopic. And if you want to have a high-end endoscope, it is so around about 100,000 euros for establishing a endoscope with high-end camera. And on the right side, you see 1.5 to 2.5 US dollar to get the high-end Da Vinci SI or Da Vinci 5. Which is also not permitted to use in Europe. We have still many problems to adapt the robotic surgery and cardiac surgery. If you look at the maintenance costs, so you need annually 10,000 euros for bringing your endoscope on the best with all this software actualization, and for robotic the maintenance costs are much higher. And we go then to operative room costs for all these disposable instruments, and there are a significant difference between two approaches to get also the cost again back. So the cost for robotic surgery is very, very high comparing to endoscopic surgery. Also, in a multidisciplinary approach, if you have all the other disciplines also in your center to get, so to use it for different disciplines. So I try to compare the operative CPP time between two different groups. We do over 200 cases of AVR per year endoscopic, and Lawrence group, they do also have a very high volume of endoscopic procedures. And you see in both very experienced expertise groups, the difference of CPP time for the robotic approach, and the cross-clamping time for simple AVR. So the time for experience time is very important in the cardiac surgery, and you see the difference of two different approaches with more expensive and more complicated setup. The learn curve, Dr. Schein has already mentioned. I think in our center, they need 50, 60 cases to get very routinely with AVR. We do 40 hours of simulation on our simulators for residents and staff surgeons before they come to the operation room. And this is the learn curve based on the literature which you need to get a level of expertise for robotic approach for cardiac surgery. So it is very complex. The learn curve is very, very complicated. So you get all these advantages which you have heard through a microincision. This is a young patient with nipple cut, which was introduced by Dr. Perrier, and they have, I think, I see no difference two approaches for getting setup of a robotic. So if you look at to the literature, there are enough evidence also for having a fully endoscopic approach for AVR, and more than 1,000 patients with various aortic valve pathologies could be operated through an endoscopic approach. No issues about the postoperative morbidity and mortality, and it is a reproducible approach and yield excellent outcomes. Looking to the mitral valve surgery, you have heard about the redo operations and also complex procedures like HOCM and all of those, and comparing also to multi-valve surgery procedures. It is safe, feasible, and also through this approach you can yield also very good complex procedures. And if you go to aortic surgery, and you see that also endoscopic approach can be achieved with very good results. So it depends on the expertise of a center. But also in this setup, we couldn't find any significant need to go for a robotic investment because of lack of some techniques to get to the next level. So I think still with endoscope and with the generation of robotics which we have now in the cardiac surgery, there is, from my perspective, no need for this investment. So this is also if you have a patient with situs inversus and aortic valve replacement, you just need to come on the left side, but the complete setup can stay at the same level as you would do a normal AVR. So I think endoscopic approach, comparing to sternotomy, it is well known. It is actually better, and you don't need that much resource utilization comparing to sternotomy, and it is enough evidence in the literature that avoiding sternotomy for all these elective cases is actually judgeable and should be a standard approach. So comparing full sternotomy with minimal invasive surgery, I think regarding costs, hospital stay, patient satisfactory, and all of those, you have a better and reasonable outcome for minimal invasive surgery. We saw the robotic approach for mid-cap, and you see this is a very simple setup for having endoscopic harvesting of a left mammary artery. You see you need only 3 hands, not a big robot, and 4 arms. Until your robot is set up, you can, after 30 minutes, you have your mammary artery harvested, and we do from the same side also the right mammary artery. So I think with this generation of robotics, there is still a discussion: should we spend this money for having a new setup for our surgery? If you go to more complex cases, and I'm talking about Bentall procedure and how it would be also possible with robotic, you see that through the same setup like aortic valve and mitral valve, you can go also for complex aortic procedures. And you see in this case a Bentall procedure with using RAM device, and we need for those cases 2 centimeters of cuff for aorta ascendens to have a secure suture line, but everything is possible. You see the buttons of your coronary arteries. It's a Bacchus with aortic valve, and how you can, with long-shafted instruments, endoscopic approach, go for a root replacement, and all these new gadgets like RAM, like Cornuts, they are very feasible to use. If there is a problem of exposure, you have enough devices to expose the aortic root and get the exposure better and better. So you see you are on the table, you can finish your conduit, you see the whole team, you're not only focused on your console, and do the operation with less invasive setup. So I think from this view, I think the more experience and expertise you have, you can perform also complex procedures and more complexity, and do also complex cases. But I do not recommend you to start with dental procedures as your first case for endoscopic approach. So I think this is the dental approach. There is also more new techniques for doing also less invasive and approach for a patient like this with older age, where you don't want to have a long ischemic time. You can also go for complex cases of root replacement. And in these cases, you see how the environment is. We have a 3D 4K 50-inch monitor. You can also do we call it reversed elephant trunk into the left ventricle and implant your aortic root prosthesis inside. And for those cases which we do for dissections to replace the aortic root, and also in older patients who need aortic root replacement, we go for a sutureless dental. And also in these cases, doing an endoscopic approach is possible without any restriction of the quality of your surgery. So again, doing the reimplantation of left coronary artery, and the right coronary artery. Actually, for normal dental, we do first the distal anastomosis and the last anastomosis, the right coronary artery. But if we're doing sutureless dental, you need to reimplant both coronary arteries and then go for and then controlling the two buttons, and then sizing the valve, and using a sutureless valve. This patient was, I think, over 75 years old, and then we decided to go for a Percival Plus. So, and you also save also another suture line, and then move to the last anastomosis and finishing the surgery. So if you go to more complex and challenging cases, also David procedure, and this is my last video, I promise. It is also the same approach. I think you cannot achieve this also with a robotic, and also in these cases, everything is with good exposure. It's a team approach. You need a good scrub nurse, you need a good assistant, but there is no restriction of the view. You can evaluate the valve. We do in these cases only tricuspid aortic valves with with only central rigor. If we have issues of prolapsing, I think this is a restriction for this approach, because you see the valve from the lateral, not completely orthograde to the valve. So this is also usable and can be achieved very good through endoscopic approach. So I think I can summarize that endoscopic valve surgery offers several advantages for your patients and your hospital. And from our perspective in Germany, we couldn't find still unmet need for invest also in robotic surgery. Thank you very much.